she had um what's it called? GERD, right?
That's what I have,
She
yeah.
had GERD and she went and self-treated it. She went to Costco, she got some Tums, she got some PPIs, it's over the counter now. And it helped stuff, but she didn't feel good on it. I was like, why don't you come to me? I have things that can help this. And I gave her that tub there and I said, all right, you're gonna take 2 scoops a day and it'll fix it like within a week. She's like, what? I've been dealing with this for years. It's not possible. I'm like, just do it. She emails me like 3 days later. She's like, this is the best thing ever. It's like fixed my GERD. This is a miracle. And she's like, can I get more tubs of this? Like, can I stockpile this? I'm like, it's not tons. It's not a PPI. It's a regenerative peptide. So it's not a pharmaceutical that you have to take long term.
Right.
You use this as a short course. It regenerates your intestinal lining, your stomach lining, and you're good. I mean, if you follow the diet, if you're not drinking alcohol, if you eat well, and if you're not drinking Diet Coke all the time, drinking a bunch of caffeine,
I quit
taking
sodas. Yeah.
NSAIDs, ibuprofen, lots of aspirin, like all that stuff will damage you again, sure, but you shouldn't have to take something like regenerative long term because it heals you.
So if, let's say I have to take ibuprofen one day because I just can't stand the pain. I take ibuprofen and it like ibuprofen is a nemesis to me. Like
Oh yeah,
my guts hate it.
right.
And that's part of why I've blown up too, right?
Yeah.
The amoxicillin, the ibuprofen.
All of that damages the intestinal lining and specifically the stomach. That's where that stuff dissolves first.
So if you took ibuprofen one day
Hmm.
and you could probably take this the same day after taking
So I've
it.
never done that. So you're talking about counteracting the effect of a
Yeah.
pharmaceutical with a regenerative peptide. It's a good theory. We haven't really tested that out because typically we try to get patients off the pharmaceuticals that are damaging the person. Use the
Understood.
regenerative peptide to heal them, and then they're in a better situation. And we try to use alternatives for pain management that don't damage the person.
Right. But what if we can't get that?
No, we can do it.
Like the cold plunge?
Correct.
Yeah, well,
It's one of many things we use for chronic pain.
what other things are besides massage and
Hmm.
acupuncture, like that I do all that.
Yeah. Hey, Francesca, you can join our Q&A here. But yeah, I have a whole gosh, I just talked to a patient about this. It was right here on the list. So pain management. We first optimize the hormones. I don't know if you can do this. Okay, you first optimize the hormones. So that's estrogen. That's helps with cartilage, helps you. It's anti-inflammatory. Progesterone is also anti-inflammatory. Is regenerative. It balances the cortisone. So give people prednisone, they give people Medrol dose packs, they inject people with steroids. These are corticosteroids. So what do corticosteroids do? They waste someone. They waste the bones, they waste the muscle, they weaken the ligaments, the tendons. The orthopedic surgeons, they know they can't give a patient this term because they degenerate. Now, should be done is you replace them with anabolic steroids. And now the conventionalist is scared. When you tell them anabolic steroids, they think of a bodybuilder abusing steroids in the gym. But they have no problem giving patient a corticosteroid, which makes them waste away. What they should be doing if they give someone a corticosteroid is they should be giving them an anabolic steroid. And this can be something as simple as DHEA. It's an over-the-counter androgen anabolic steroid. You can give them pregnenolone, which is the precursor to cortisone that helps replace the cortisone that's being used. And you can give them testosterone. That's an anabolic steroid. That's women need that just as well as men. And you can give them other anabolic steroids. This is like nandrolone or even oxandrolone. These are things that have been studied specifically in patients that use corticosteroids long term because the anabolic steroids they counteract the degenerative effects of the corticosteroids. So that's all part of the hormone replacement, right? We try to fix the hormones. Sure, you can give some cortisone to cool off the inflammation, balance it with the other hormones. And then the diet is very important. You want to avoid the inflammatory foods, the gluten, the processed breads. This causes pains. You can give them collagen that helps support the joints. It's a great peptide. More protein intake, making sure you're eating enough that can build the muscle. You don't want to undereat protein, eat too much sugar, processed breads, and you're not going to have the amino acids to heal the body. The peptides we use for acute treatment of pain to help regenerate. So you can use the Wolverine peptides, you can use the gut peptides to heal the gut inflammation. We typically will use these short term for an acute injury because they accelerate the healing process. They accelerate collagen synthesis, tissue repair, muscle, bone, tendon. So typically we use BPC 157 and thymosin beta 4 for this. Um, I mean, they're not cheap, but they're not expensive either, like some of these other things like exosomes. So exosomes is the new way we're delivering stem cells to patients now. They're very expensive, and they're difficult to acquire. They're only from C-section donations of umbilical cords. Then they have to go to a lab. You have to extract the exosomes. It's very expensive to extract them and keep them frozen, and then they have to be shipped to me overnight on like nitrogen, and I have to use them within 72 hours. Okay. I don't always do this. They cost like $1,000 for like 2 mLs. It's crazy. There's other peptides that help with regeneration, like sabinitide. And then there's pain management. We use low dose naltrexone, LDN therapy a lot. This is an anti-inflammatory. It's not addictive. It's actually the opioid antagonist, naltrexone. Naltrexone is used for heroin addicts because it blocks the opiate receptors in the brain. They can't get high off it. But that's at 50 to 100 milligrams. We use 1 milligram, maybe to 3 milligram. A low dose of naltrexone has been found to release endorphins in the brain. That makes people feel good. It's what the runners try to achieve by long distance running. They get a runner's high off of it. It helps their anxiety, their depression, their pain. It also helps improve the immune system and it modulates inflammatory autoimmune diseases. So it's been studied in lupus, um, neuropathic disorders,
So
Parkinson's.
it won't cause the same damage as ibuprofen.
Absolutely not. It's one of the most benign drugs we've found. The worst it can give you is some strong dreams. It helps sometimes people sleep. Their sleep gets better on it. And then, of course, the Morosco Cold Forge, freezing cold temperatures. We found that for pain management, you have to get down to 35 degrees Fahrenheit. The water has to have ice in it. If you get in these cold tubs, 50, 40 degrees, it's not as good. You don't get that relief. This, everyone gets a relief. Every person we put in there and we've had them do, we have them do a survey. They, um, they all get better. Maybe not complete, and sometimes they have to come every day. Some people have to come maybe 3 times a week. Some people need to do 11 minutes. Some people need to do 3 minutes. So there's a whole range of how long someone needs, and it depends on how bad their pain is and how much insulation they have. So if they're a little bit more overweight, they need to be longer in there for the cold to get to the tissue that to cool it off. So thinner people, they're in and out like me. I'm in and out of there in like 90 seconds. I'm frozen. You know, the pain's gone. And then there's NIR and light therapy. This also promotes tissue healing, collagen synthesis, and also nerve regeneration.
Yeah.
We had a patient out here. She had trigeminal neuralgia from, we think it was like a zoster, like a herpes zoster that, and then she had chronic nerve damage and she was in severe pain, like 9 out of 10 pain. It was severe. She was thinking about getting surgery for it. And there's a surgery for it where they can ablate the cranial, they can cut the nerve, but it's kind of experimental still, and I don't know if it works so well.
That's crazy.
We put her in front of the red light, and it went away with a bit of massage therapy and red light over the course of a couple
Yeah.
weeks.
Love that red light.
Amazing. And then, of course, building the muscle. So doing some level of physical therapy or just some strength training with a personal trainer or a coach to try to build back the muscle that may have atrophied from not training. So if you have pain, you don't want to train. So we first do everything else here. We try to fix the pain. When the pain starts getting better, you got to do the PT. You got to do the training to help heal movement. If you sit still, you don't move, you're going to get tighter. The ligaments are going to get tighter. You can get worst case scenario, frozen shoulder syndrome. That's terrible. You never want adhesive capsulitis. Terrible condition. Vibration plate. So moving the lymphatic system, getting those tissues to move a little bit, break up the scar tissue. We like that. And then sauna also seems to have a relaxing effect on the muscle, especially if there's like a muscle contraction component. It's just a lot of people's problem. Do the sauna, also make sure they're taking enough electrolytes, potassium, magnesium, and so forth. Nitric oxide to get blood flow moving, oxygenation to the tissue. Oxygenation, I should put that on the list as well, because you need oxygen for tissues to heal. And for that, you can do hyperbaric chamber, HBO2. That's a great way. It increases stem cell release. Getting more oxygen to the tissues helps the body heal. But it's expensive. I mean, we do have it available. You can go for sessions at Mom's place. She's here on the chat. And she'll put you in there. It's not good for a claustrophobic, I'll tell you that. But if you're not claustrophobic and you have time for about an hour session and $50, you can go there and do it. Another way to do it is with the EWAT that we have out back, and that's exercise with oxygen therapy. So you breathe through a mask, about 97% pure oxygen. So it's the same type of compressor system that delivers oxygen to the hyperbaric chamber. But you're on a bike, you train for about 7 minutes, and you get high oxygen to the tissues. The idea is you get oxygen to the tissues and you start healing because oxygen heals tissues. So and that's why we like exercise. That's why we like nitric oxide, vitamins like magnesium. So you get oxygen to your tissues so you can heal again. So that's our approach to pain management. You can see ibuprofen is nowhere even on this list. I don't even use it. I mean, you could do corticosteroids, hydrocortisone. So hydrocortisone, about 30 milligrams. 30 milligrams of hydrocortisone is a physiologic dose. So when you wake up in the morning, you naturally produce cortisone. But in some patients, they don't produce enough cortisone and they can have chronic inflammatory diseases and they use up all their cortisone. So they're always inflamed.
So how do you know if that patient has that problem?
Well, you can test it. You can do salivary cortisol testing to see if they, or you can just give them cortisone. They'll probably feel better if they have pain. But you give them physiologic, you don't give them super physiologic. So what is super physiologic? That is dexamethasone, that is prednisone, that is Medrol dose pack. These are super physiological. So between 40 and like 90 times the dose that you would produce naturally. The problem with that long term is you swell up, you get fatter, and your tissues degenerate. Your body really only needs about 30 milligrams a day. So you can give them, that's bioidentical hormone replacement, hydrocortisone. You can get it at CVS. It's not expensive. But to do that, you also want to balance it. That means the anabolic steroids as well, DHEA and testosterone at a bare minimum, right?
Or you take nothing and you don't have to take any of it then.
Right. And so if we can figure out how to treat the pain alternatively, you don't need to take the cortisone. Um, the other hormones, yes, DHEA, pregnenolone, I think those are very important to give you the ability to produce your own cortisone and your own anabolic steroids like testosterone.
Especially as we get older, we can't make the hormones like we used to.
Right. You deplete the hormones in two cases. One with age, everyone declines hormones with age, and then two in disease states. You will burn through the hormones more. So disease states like inflammatory bowel disorders, you use up all your cortisone to cool off your own gut. If you have rheumatological conditions, you burn through your own cortisone. But then there's also the patients with traumatic brain injuries. If you've gotten hit in the head, football players and so forth, even like soccer players, I mean, repetitive concussions to the brain, it can turn off your pituitary. So you don't produce growth hormone. You may not produce the precursor hormones, pregnenolone, testosterone. You can check these patients, and lo and behold, they don't have any hormones left, and they're gone. And then you replace them, and they feel better, and they start healing again. Mhm. Francesca says she's using red light now for shingles and it's helping with the discomfort. Yeah, good. It's going to help with the nerves, the cooling off of the inflammation of the nerves. And that's what shingles is. It's a neuroinflammatory disease. It affects your nervous system and the dermatomes. So it makes a lot of sense to use the red light therapy for nerve damage like that. Yeah. Yeah. What I, that whole pain management business, um, a little not a lot of people know this, but the my a good friend of mine who helped me start this practice, his name is Dr. Bradley Goodman. He's an MD. He's very good at what he does. He's an interventional pain management specialist. And he does very well for himself. He's told me there's no such thing as a good pain management therapy. Comes from somebody who's board certified in this, has been doing it for the past 40 years. He's expert at what he does. He's very good at it. But he says there's no good pain management. And that's he's talking about the conventional pain management. And that means the prednisone, the injection of steroids, the surgeries, the spine fusions, the ibuprofen, the muscle relaxers. He says that is not good. None of it.
It's not.
That's why he really enjoys what I do here, going towards a different approach of helping people heal. He's living vicariously through what I'm doing here. We're doing everything but the conventional. Mm. I mean, there might be a time and place for it. I think the best way to use the conventional would be you get the steroid injection and it allows you to get to movement again. It allows you to do the physical therapy and the rehab to attempt to heal. That's the best possible outcome with that.
But that messes you up too.
What part?
The cortisone shot.
The cortisone shots, yeah. I mean, but if they're used little dose at a targeted level, so you can do
Like,
fluoroscopy. Well, typically they go under radiographic imaging and they shoot a little dye in there and they see where they're going and they inject just a little bit of a steroid to cool it off. But oftentimes that procedure is just used as a diagnostic tool to then do the rhizotomy. And so it's actually a burning of the nerve. So they will ablate the nerve in the rhizotomy procedure after if the prednisone and lidocaine procedure works. So it's just used as a diagnostic. They burn the nerve and typically the nerve will regenerate in about 4 to 6 months. And then that's supposed to give the patient time to do the rehab, the chiropractic, the physical therapy to recondition themselves. But when I worked in pain management, that's not really what I saw. I just saw people coming in for a tire rotation every 4 to 6 months. They
yeah,
did, they didn't get better.
they follow the direction.
I guess, but then they don't have the ability to heal. They're not eating the right diet. They don't have the hormones to heal. Maybe physical therapy can work in someone very young who has the good diet and the hormones.
Maybe. I don't know. Sometimes when I get those cortisone shots, I feel like I'm depressed afterwards. I feel like crap. So
Yes.
I think it turns maybe other people, it turns them off and they stop exercising and eating right because they're still in pain.
Yeah, the cortisone, the steroids, they have psychological implications. They will oftentimes make people irritable, anxious, depressed. So
Yeah,
that's a common side effect.
I should probably throws people, they're already in pain, it throws them off totally.
Mm-hmm.
It's just downward spiral.
Yeah, exactly. Francesca asks, HRT for women, can you expand upon how to use the suppository with progesterone cream and oral pill? Do you cycle the cream and do you use the pill daily? Well, that depends what your objectives are. So if you're using a suppository of hormones, one, it's a great way to deliver hormones systemically because the vaginal mucosa, it absorbs things remarkably well. But the second way is to use hormones for a local regenerative effect. If you have a vaginal dryness, if you have urinary incontinence, if you have dyspareunia, which is pain with intercourse, using a suppository of hormones can regenerate the lining, and women can get an amazing relief out of this. I mean, I had one patient the other day. She told me she had given up horse riding because she would urinate on herself every time she got on her horse because of the impacts. And then we put her on the suppositories, was able to regenerate her enough where she enjoys horse riding again. I have another lady. She's 63. She had written off having a boyfriend ever again. She thought her days were done. I got her on suppositories, and I mean, she has sex drive again. She has a boyfriend. She's dating again. I mean, she's enjoying life. Um, but then the downside of that is that she broke up with her boyfriend and she had all this libido and sex drive, but no outlet. And she actually stopped the hormones because of that. And I was like, well, the hormones, yes, they're great for libido, and it's probably the most noticeable effect. but it helps you heal. It helps with pain. It prevents you from getting infections so much. It prevents Alzheimer's, cardiac disease. So you don't go off your hormones. Maybe we can reduce the dose on the testosterone if the libido is too high. Sure. But the hormones are more than just libido. They're everything. They help you heal your immune system. So that's why we would do a targeted and a systemic approach. Now the progesterone, yes, there's two ways to do it. You can do oral progesterone that helps women sleep at night, helps them relax, can help with pain, of course, because it's anti-inflammatory. It's a neurosteroid as well, so it decreases pain signals in the brain. It's a bit sedating too, so it helps you relax and go to sleep at night. But then the progesterone, it balances the estrogens. So we always give progesterone to women to balance the estrone and the estradiol. They're not bad, but if they're not balanced, you can get proliferation. So you can get growth in the breast, cysts in the breast tenderness. You can get ovarian cysts, endometrial hyperplasia, so overgrowth of the uterine lining. This is a really big problem in our society. More and more young women are having this. And when we do the labs, we see young women, they don't cycle their progesterone anymore. So we have women test their luteal phase hormones. So we look at the balance of estrogen to progesterone. So we have them go to the lab about day 19 through 21. And what we want to see is we want to see progesterone come up and balance the estrogen. Lo and behold, many times we'll send a young woman to the lab and they have zero progesterone on day 19 or 20 of their cycle. So they're not balancing their estrogen. They don't have progesterone. This puts them at risk for developing all these problems that women get, the breast masses and so forth. So can put young women on progesterone as well. Now, how might they do that? They would cycle it. So you cycle the progesterone. The progesterone, it comes up during the luteal phase, and then it drops off precipitously, and by day 28, it's gone. And this allows the bleed to happen. And that's normal and intended. Progesterone, it's a good hormone, but it balances estrogen and it dries up the it can dry up the bleeding. So if you're a postmenopausal woman and you don't want to bleed and you don't want to have a cycle, but you like the estrogen effect, you take the progesterone to balance it, right? And if you want to do a different approach, there's some in functional medicine like Dr. Felice Gersh. She is famous now or infamous for having her postmenopausal patients still have a menstrual bleed. So she will have them cycle their progesterone day 15 through 27 like they were younger. And her reasoning for this is because your cycle is your fountain of youth. And so you want to maintain this because it's healthy. But it's a hard sell when you're telling someone who is had the benefit of not having a period for some time that they should have a period because it's healthy for them. So I have very few patients that will do this. So typically we just give them the progesterone at night to sleep. Now the progesterone topically has a local effect. If you apply the progesterone to a woman who has one breast that's larger than the other, you have them apply it to the breast that is larger, and it will shrink the tissue and even out the breast. You can also apply it equally to the breast tissue for women with pain. So if they have fibrocystic breast disease, or maybe they have a pain on their ovaries or uterus, you can use it transdermally and it will have a local effect as well as a systemic absorption effect. You can also apply it to the face as an anti-aging wrinkle cream, the same as you might with topical estradiol. They both have anti-wrinkle effects. So those are the reasons you might use the various hormones, both for a systemic benefit, because if you put a hormone on or if you take it orally, it will work systemically. But if you apply it topically, it has a local benefit as well. And of course, the iodine plays a role in that too. You want to make sure you take iodine because it helps detox the high estrogens. And if you give enough iodine to young women, they may even produce enough progesterone on their own. Now, the progesterone is the first hormone to decline perimenopausally. So, for some women, it happens earlier. If they've had some more kids, they can hit menopause and perimenopause much earlier, age 35 sometimes. But if they've delayed having children a little bit later in life or they don't have children, they still may produce progesterone quite later in life, and they may still have a good hormonal balance. It's very dependent on the woman. they may not produce as much progesterone as they once did, and maybe they don't sleep as well. So you can give them some progesterone, they'll sleep again. So hopefully that answers some of those questions there. So she's asking, so can I take both? Take the pill for sleep and cycle the cream? Yes, the answer is yes. You can cycle the cream, especially if you're having a breast tenderness from higher estrogen. The other option is to decrease the estrogen if you're having breast tenderness or increase the iodine. It's all about trying to find the right balance that works for you. Uh, you know, women who, there's two types of women that will have high responses to estrogen. One is one woman with very good circulation. So they have good thyroid function and they have good circulation. You apply a little hormone to the skin and it absorbs very well. And they feel good off a little estrogen. So they need a very little dose. And then the other is a woman who is a little bit poor circulation that transdermal estrogen doesn't absorb very well. So they need a little bit of a higher dose. And then there's the woman who has a little bit more fat cells. If you have more fat cells, you can actually produce estrogens. You produce primarily a form of estrogen known as estrone. Estrone is a bit of a problematic one. It's a bit more inflammatory. So that's not one we'd like to see super high. We like to see estradiol a little bit higher. But unfortunately, women with more fat cells, they produce estrone and that can give them estrogen symptoms. So breast tenderness, uterine cramps, maybe even bleeding. So they need potentially a little bit less estrogen. Maybe they need a little bit more progesterone to detox the estrogens. So that's something we encounter sometimes. Let's see. We only have two people in the Q&A. Oh, what else? Any other hot topics? Covered pain, covered hormones. It's pretty good. All right. Yeah, if that's all, that's a good lecture. We can close it down. I don't think we'll get anybody else in the chat. Very good. Thanks for joining you all. Maybe we'll do this another time. Bye.